I now have the honor of introducing our second star, one who in the bio, I think you can see somewhat of a summary of some of Rinad's key contributions and status. Let me add just a couple of personal notes. Rinad and I first met a number of years ago when she was a trainee in the Implementation Research Institute, one of the first implementation training programs. Very quickly illustrated the concept of having the student surpass the teacher, where her accomplishments quickly surpassed those of all of us as core faculty. As is the case with Bethany and Jonathan, as we'll hear in a few minutes, a variety of contributions, one in particular that you'll talk about today, and that is the role of behavioral economics in strengthening and complementing implementation science. The other quick personal point is that Rinad is not a very good role model for other junior faculty, now senior faculty, in terms of what to aspire to, because the amount of academic productivity, her role as a leader of an 80-person department next door, her role as a mother, is something that I don't quite see how it's feasible, but she manages to pull it off. So Rinad, thank you for joining us, and the floor is yours.
Thanks for that very kind introduction, Brian. It is a huge honor to be up on the stage with these folks chatting with you all today. Welcome to Chicago. It's pretty warm here, so you all lucked out, although I will say it's been a mild winter. I want to start by just thanking all of the folks who have been on this journey as a team, thinking about how to incorporate insights from implementation science and behavioral economics together. So we've heard a lot about what implementation science is, thinking about how to engage constituents. And I'm going to kind of present I'm sorry, am I really loud? Should I back up a little bit more? I tend to talk loud to begin with, so I don't want to, it's too early in the morning to hear me this loud. So I'm going to tell you about a particular kind of intersection of two disciplines that I think holds a lot of promise as we think about how to support clinician behavior change within organizational constraints, which is fundamentally what implementation science is all about. But I just want to call out Kevin Volk, David Ash, Allison Buttenheim, David Mandel, Justin Beckelman, and Robbie Schnoll, who have been key partners in this journey. I do like to start all of my talks by sharing a little bit about my own personal identities and lived experiences, because it really does shape how I think about this work and why I'm so excited about it. You already heard from Brian a little bit about my background, but I am a psychologist by training who lives, breathes, and eats implementation science. I'm a mother. I have more recently been interested in behavioral economics, and I'm a first-generation immigrant from the Middle East. And I really, what gets me up in the morning is thinking about the promise of these tools in advocating and amplifying the needs of our communities and moving towards achieving population health and social justice at scale. And implementation science is an imperfect discipline. No discipline will move us fully toward where we'd like to be. But I really think it holds a lot of promise, and that's why I'm so excited and eager to share this with you today. I also like to start my talks by telling you what I'm going to tell you in case you want to take a snooze or you're looking at email. So the main takeaway really is the nexus of behavioral economics and implementation science, in my opinion, has the potential to really transform the seemingly intractable challenge of moving the needle in healthcare equitably. And I'll tell you why now, and we'll see if you agree with me. So you might wonder, how did I become interested in this intersection as somebody who kind of came into the field as a hardcore all in on implementation science? And actually, Brian, it was at that Tighter Institute when we met where it may have been you. You may have been the one that have started me on this this path. But I heard about behavioral economics for the first time there, but I didn't really find my way to it until these two key insights. So I mentioned that I'm a psychologist by training. And so my early work was really focused on children's behavioral health because that was my clinical expertise. Now I do this work in lots of different disease areas and settings. But as part of my early work, I spent 10 years kind of deeply embedded within the city of Philadelphia public behavioral health system. And what I was doing there as part of a career development award from NIMH was really trying to understand clinician and organizational factors that might be associated with implementation of evidence-based practices using quantitative and qualitative methods. And you saw a similar graphic in Brian's slide of pushing the rock up the hill. But really what I learned from the qualitative work, which I did in collaboration with Becca Stewart, pictured there, is that it's really hard for clinicians and organizations to do evidence-based practices, particularly in resource-constrained settings, which, public behavioral health is probably the most prime example of that. However, I work in health systems, and given the burnout and what we're seeing, they're actually starting to look a lot like those public behavioral health systems to me. But we heard about Maslow's hierarchy of needs for these public behavioral health systems, and that evidence-based practices and implementation is kind of like self-actualization. They're just worried about paying their folks staying open for a month. And I did this big study as part of my K-23, and this was the headline in the Philly Inquirer: slow change. And you could replace children's therapy with probably any area, including your own areas. And I was puzzled by this because the system was actually putting so many resources into implementation, and we were still getting this friction. The second insight started early in 2011 when I heard about behavioral economics for the first time, was that I was at the University of Pennsylvania for the start of my career. And Penn is really strong in the area of behavioral economics. And so I realized that there would be an opportunity to partner with colleagues who are experts in this space. And we have 2 center grants, one in mental health and one in cancer, to really explore the methodological intersection of these areas. I also had the great fortune of being the second director of the Penn Medicine Nudge Unit, which is the first behavioral design team embedded within a health system to bring insights from behavioral economics and implementation science to the bedside. So maybe I'll make this interactive. Does anyone here want to define behavioral economics? Not seeing a lot of hands. Okay, I'll try it a different way. Raise your hand if you've heard the term behavioral economics before. Okay, so almost everyone. So I'm not seeing a lot of people wanting to kind of volunteer, which is fine. I do want to make a point, though, that there's a common misconception when I say behavioral economics that people think it's either health economics, so the cost of the interventions that we're trying to implement, that's a whole separate area, or that it means that we're going to pay people to do the things that we want them to do or give them financial incentives. And that's actually not what behavioral economics is. So let me illustrate for you what it is from some other areas, and then bring it back to healthcare. So this is a subway in Stockholm. Volkswagen was doing a campaign, and they painted the stairs like a piano. How many of you would take the escalator or those stairs if you were faced with that option? So raise your hand if you take the escalator. Raise your hand if you take the stairs. So that's indeed what they saw. It makes it more fun and attractive, and people are more likely to take the stairs when you paint them like a piano, playing chopsticks versus the escalator. Here's another example. It's about smoking, so take it with a grain of salt. But basically what you can see here in London is there's a trash for cigarette butts, and it asks people to vote who's the best player in the world for football. I have a 10-year-old son who would say it's definitely Ronaldo and not Messi. But you can see here how these types of fun, attractive solutions make it more likely for people to engage in the behavior that we're looking for. This is something we may all have experienced. Who here has been watching Netflix or streaming and it just goes on to the next show and 3 hours later, you're like, what happened? I'm not sure. I'll raise my hand because I think it may have happened last night. So this is a digital nudging kind of behavioral economics example, but the default is to just keep watching. And so we do. So I think what really drew me to this, and Brian mentioned this in his presentation about making it easier to do the right thing, is can we use these principles of behavioral economics, and we call it choice architecture, designing the environment to make it more likely that the individual will do what we're hoping they'll do, the evidence-based choice. Can we make it easier for clinicians and organizations? And I just want to say, I'm a clinician myself. And I think clinicians work really hard. And I think every clinician is trying to do the best that they can in that moment with that patient in front of them. And we often are asking them to do hard things that make it harder for them to do their job. And so, you know, the concept here is, instead of making it harder, are there ways that we can make it easier? I do want to share with you this slide, which I believe is kind of a helpful way for us to understand how behavioral economics has emerged in the kind of literature and how the thinking of behavior change has evolved. So early on, if you want to think about it as like behavior 1.0, you know, we thought if we just tell people, we give them knowledge, they're going to change their behavior. Obviously, that didn't happen. It's necessary, but not sufficient, as Brian pointed out. So behavior 2.0, or standard economics model, is that we all are maximizing utility at any given moment in terms of our decision making. So we're thinking of all the pros and cons of what will be best for us. And we have complete insight into all the decisions that we make. And that's where this idea of like, well, if you pay someone more, obviously the utility is that you would do more of the behavior, right? So that was kind of 2.0. 3.0, which is behavioral economics, is that we have known regularities in how we behave as humans, and we've evolved in this way for very adaptive reasons. And we can kind of leverage or harness those ways of thinking and those decision-making skills to make it easier for people to engage in the way that we're hoping for them to. And I'll give you examples of that. Sorry, I forgot about the stars. So I would argue implementation science is still kind of more in the standard model of like, if we tell people and we throw all these resources at behavior change, it will happen. And I think the future is incorporating some of this thinking into our approaches. So, I hope you'll think about some of them in your own use cases and examples. So ultimately what that means is that we need to be designing our science less for how we hope people will behave and more for how they actually behave. And, bounded rationality, dual process theory is kind of the background to this. If you're interested in this, there's a lay book called Nudge, which, shares these insights in a way that's very approachable. But, we don't have all the information. We're working really hard under enormous constraints. And we use mental shortcuts to make our decisions. And we do this clinically. It's not just whether or not I went to the gym this morning, which I did not, because surgeons always start their days very early. But that we can, harness these patterns to design more effective implementation strategies. So I just want to give you a little evidence that clinicians are humans, and for this idea that we should design for how we hope, how people behave rather than how we hope. So this x-axis is primary care visit appointment time, and the y-axis is the percentage of patients who are either have a clinician order of a mammogram or patient completion. So blue is the clinician order, orange is patient completion. And what you see here is a pattern we see across all kinds of fields. Over the course of the day, clinicians order less mammograms, patients complete less mammograms. And actually, fun fact, this is true for judges as well. So judges are the most lenient at the very beginning of the morning. And then over the course of the day, they become more strict, and then they have lunch and they get lenient again, and then it goes back down. My takeaway is see your doctor or your judge first thing in the morning. But this is due to the fact that doctors are making decisions all day, they get backed up, it's common sense, but it's evidence for how this works and how this plays out in the clinical environment. This is an example of one of our most powerful behavioral economic strategies, which is changing the default. And this was work led by Mitesh Patel, who's the first director of the Nudge Unit at Penn Medicine. And essentially, I go back. The red button. No, it's going forward. Oh, you know what? This is not matching that. Okay, you already saw the punchline, but I'm going to tell you anyway. So I'm going to face this way because this is, yeah, perfect. So essentially what happened at Penn Medicine is that 2014, they changed the default in the electronic health record where the default became generic formulations for drugs. And before that change, you see a lot of heterogeneity in clinician behavior around prescribing patterns. And then after that change, nope. Perfect. After that change, you see a tremendous lack of heterogeneity with one drug. Does anyone know what drug clinicians don't like to prescribe generic? The test. Synthroid. So essentially what you see is clinicians were still able to keep their autonomy. If they didn't like the default, they could change it. But for things that they didn't care about, it was easier. You could think about the default in lots of different ways. How many people here have changed the default setting on your iPhone? Probably not many. We just kind of go with what it comes to us with. So, you know, behavioral economics really offers some key principles for thinking about how we design the strategies to support clinician behavior within organizational constraints. And one mnemonic or helpful way to think about this is the EAST framework. So we can make it easy for people to do the desired behavior change, make it attractive. Think about that subway example. Make it social. So clinicians are very kind of linked into their social networks. So if you do things like peer comparison, that can be a helpful way. Of course, there can be unintended consequences. And then timely. So really thinking about when people might be most receptive to this kind of approach or nudge or prompt to do an evidence-based behavior. So when you go to the implementation science literature, we have something called ERIC, or the behavior change wheel, which are these taxonomies of behavior change approaches. You don't see these types of strategies as represented in our existing taxonomies. And so this is actually a ladder, and the higher you go on the ladder, the more effective or robust the effect is in terms of changing behavior. And there have been some reviews done that demonstrate that the default tends to be the strongest way that, you know, we can shape behavior if we're looking to change behavior. So I want to give you an example of what a study that brings together behavioral economics and implementation science looks like. This is an R01 that I'm the PI of, and it's focused on secure firearm storage as a universal suicide prevention strategy in pediatric primary care settings. And the real main point of this trial is to ask the question of whether or not we could take a behavioral economic approach, a nudge, or changing the well-child visit template in the electronic health record. And if that was enough to change clinician behavior to increase the implementation of this brief secure firearm storage program, or if we needed to provide additional support to the clinic in the form of this implementation approach called facilitation. So we did this study at Kaiser Permanente, Colorado, and Henry Ford Health in Michigan. There's some implementation science mumbo jumbo on this slide in terms of it being a hybrid type 3 effectiveness implementation trial. Basically what this means is that we were just really interested in the implementation and also looking at effectiveness outcomes, but primarily interested in implementation. We had 30 clinics, 204 clinicians, and this was, you know, over 45,000 well-child visits. So we randomized half the clinics to just get that change in the electronic health record to the well-child visit template, prompting clinicians to deliver the program. And the other half of the clinics got the nudge plus facilitation. And you may have heard Brian talk about mechanisms and mediators. We are measuring how our implementation strategy worked. We're measuring something called adaptive reserve, which is how well the clinic was able to absorb the new innovation. And just in case you're wondering, the thing or the intervention that we were trying to deploy is basically a less than 1 minute discussion between a clinician and a parent about secure firearm storage with a handout and a firearm cable lock offered for free. And you can see here that actually the prompt in the electronic health record differed by system, but it had the same kind of function to prompt the clinician because we wanted to integrate it into workflow. So I don't see people Xing or tweeting or whatever it's called now, but this is still not published, so please don't share this beyond this room. But we're really, really excited about the findings. So at baseline, and you don't see that here, only about 2% of clinicians did this intervention that we were hoping that they would do. After running the study, what we found, the primary study question, is that patients, kids and parents presenting to clinics who got that additional facilitation or support to the clinic were 2.2 times more likely to receive safe firearm, which is the thing or the intervention we were trying to have them do. So 54% of families, up from that 2%. And the nudge alone is no slouch either. That's a relatively light lift intervention. And 22% of families received it with just that electronic health record change. And you might say, well, facilitation isn't something scalable, but it was less than an hour a month for each clinic. And so, if you think about that, you could imagine a facilitation workforce to kind of support behavior change within the context of health systems. I don't want to overpromise. I showed you early that Patel study where behavior change was almost kind of 100%. Behavioral economics alone is not going to be a panacea. There is no silver bullet. This is hard work. And we have a hard context to work within. We have to attend to the basic needs of clinicians and organizations if we expect them to be functioning within a learning health system. And structural problems require structural solutions. There is some concern that these kind of sexy individual level nudges might kind of make it easier for decision makers to invest in those versus the structural changes that are needed to actually improve outcomes and well-being within healthcare systems. There's lots of other exciting directions. I'm not going to go through this because I only have 1 minute left, but wanted you all to have this. This is just kind of the start of bringing together these two disciplines. And there's a lot of people starting to do this work. So I'm looking forward to what we learn. And hopefully you feel that the nexus of these two areas does have a lot of potential when you think about incorporating it into your own thinking. I have to leave because that's the problem of being in the same city as the conference. But if you want to reach out to me, please do. I'd love to chat about how to apply these concepts in your work. Thank you very much.